Hello, friends. So today I'll be talking on this topic, snake bite. So I'll give a brief overview. So it appears very simple topic, but this has come in 2022 DNB Critical Care as a question. So it's good to know salient features and salient aspects that is meant to be known for all the trainees. So I wish to acknowledge my colleague, Dr. Ambika, who helped me develop this content. So when you look at snake bites, so annually around 562 deaths happen. So 0.47% of the total deaths are constituted by snake bites. And it's known to occur commonly in males 15 to 29 years of age. And per year, the number of deaths that happen across is 45,900 deaths per year happen. So this is the sort of a impact of this snake bite. So when you look at the Indian data, the leading state appears to be in Andhra Pradesh. So this has the maximum snake bites, followed by Uttar Pradesh, followed by Bihar, and this is followed by Tamil Nadu and West Bengal, Maharashtra, and Kerala. So these are the states which have highest number of snake bites. So as you see, the highest is in Andhra Pradesh. So that is something one needs to keep in mind, followed by UP, Bihar, Maharashtra, West Bengal, and Kerala. So that is the sort of a burden in our country. So when you look at the snake bite, generally there are fang marks that appear at the site of the bite, and there can be bleeding also. If it is a hematotoxic snake bite, then you would have bleeding at the site, and there can be swelling also at the site. So these are some of the local features which possibly indicate to you that someone has had a snake bite. So another important aspect is if the crate bites. So this is something which is for every intensive care listener needs to bear in mind. So crate bite may not have fang marks and they may not even have pain. So this is something which can go unnoticed. So that is something which we need to bear in mind, especially when someone comes with some neurotoxic manifestation or hematotoxic manifestation. But 70% of the snake bites are non-venomous. That is something which we need to bear in mind. So once you recognize a patient with a snake bite, so with obviously these features of fang mark, bleeding or swelling, the key aspect is to immobilize. So wherever the snake has bitten, whichever limb, the most commonest site would be the limbs, either lower limbs or upper limb. So the key aspect is to immobilize the limb with whatever uh, sort of a modality that is available at this point of time. So most of the times you would agree that a snake bite tend to happen in the rural areas. So you can have a stick placed so that the limb becomes immobile, a branch of a tree or something of that sort, and tie it. So, but when you are doing this immobilization, care has to be taken so that during the immobilization attempt, there should not be impeding of any of the blood circulation. So that is the key component that one should bear in mind. And whatever tie you are doing should not be with lot of pressure, and it should not impede the blood supply, or it should not impede any of the blood circulation. This is something which is very important to be borne in mind when a limb immobilization is being done for such a bite. So when you look at the first aid of these venomous bites, so you have to place the position of a patient either in lateral position or prone also if needs be. This is to prevent any aspiration or any secretions or any sort of an airway protection. They have to be placed in left lateral position. And it is important that the patient after the snake bite should not be walking, should not run, or should not drive. So the reason why we say that is most of this, whatever I'm talking, has been taken from most of the accepted guidelines and from the WHO guidelines. Because the key aspect is to limit the circulation of the venom. So we should not allow any movement of the patient. This is also very important. More so as a public health sort of a education, this awareness needs to be incorporated that after a snake bite, patient should just remain immobile at any place. And if there is a covering around the snake bite, especially in India, if you have rings or if you have a hand bands or if you have any threads around, all that has to be cut and the area has to be exposed because the reason is the swelling ensues. If it is in the finger or the toes, there will be swelling. And then it can, and if you have a rings around, it can lead to gangrene of the limb because of the impeding of the blood circulation. So all the clothing, watch, ring, chains, everything has to be removed from the site where the snake has bitten. and patient could develop some allergic reactions with blistering or maculopapular sort of a skin rash. And these blisters, if they appear, they should not be touched or should not be handled. They should just be left alone and be observed. So because these could be infected sites, and any manipulation can lead to the spread of the venom. And keep a close eye if patient is developing any neuromuscular weakness. So if someone is developing a ptosis or unable to open the eye, please inform the doctor as soon as you arrive at any first aid center or any hospital or a primary health care. So these are some of the features that one could keep in mind when you are dealing with snake bite. So there are certain don'ts in snake bite. So generally the recommendation is after the snake has bitten, the person who's been bitten should not go chasing the snake to kill the snake or catch the snake, because that could lead to more problems. And all these herbal remedies or any sort of a traditional remedies are found to be useless in snake bite. So don't adopt putting any turmeric or putting any of the herbal solutions, any leaves. All this has been shown to be of no benefit in these bites. And another important aspect is, so even in the past, there would be some talk about making an incision at the site of the bite to allow the venom to come out. So all this needs to be avoided. So there should not be any incisions or any skin incisions that need to be put at the site of the bite. All this needs to be avoided. And even WHO recommends that there should not be any attempt to clean the wound or rub the wound or squeeze the wound, because all this will lead to the spread of the venom. So this is very important even for a trainee like an intensivist, not to manipulate the wound or handle the wound without having administered anti-snake venom serum, because all this will facilitate spread of the venom to the proximal regions and lead to more problems. And they should not, and even there is recommendation not to apply any chemicals or herbs or any other solution. So wound has to be just left alone and not to be manipulated is what has been recommended. And even there is no role for applying anti-snake venom serum locally, because some people may apply anti-snake venom serum, even that has not found to be beneficial. And this is also important not to tie any tourniquet, because this tourniquet has shown to impede the blood supply and which can lead to gangrene of the limbs, and that needs to be avoided. So the tourniquet also should not be uh, tied, and this can lead to problems. But there is a suggestion, even from all the guidelines, that a crepe bandage, elastic crepe bandage, could be applied on the wound, and this has to be done by a healthcare worker so that the pressure is just about enough. It should not be too sort of a tight so that there is an impediment, there is impeding of any of the blood circulation. So elastic crepe bandage could be applied with an intent to immobilize the limb. That's all it is. And tourniquets definitely to be avoided. So these are some of the don'ts for all the ICU trainees to bear in mind. So when we talk about clinical features, there are two broad categories. There is a local envenomation that can happen, and there can be systemic envenomation that can happen. So local envenomation is at the site of the bite. The patients can have, as I said, bleeding, or they can have swelling, they can have cellulitis, and they can have necrosis of the skin or devitalizing of the muscles and tissues and the skin. So all these are features of local envenomation. These are important because any sign of local envenomation, or because as I said, 70% are non-venomous. But if you have any signs of local envenomation or systemic, then it's an indication that anti-snake venom serum has to be given. And the systemic envenomation, you put it into two broad categories, neurotoxic and hematotoxic. So neurotoxic, please watch for ptosis or any difficulty in swallowing or extensive bleeding in any of the sites. Predominantly, you'll see a lot of bleeding at the site of the bite or at the site of any of the injuries that patient have had. And one has to keep a close eye on the kidney functions, because acute kidney injury due to the rhabdomyolysis or the myonecrosis can set in at some stage. That is something that one needs to keep an eye on. And there are certain other ancillary features. After a snake, patients can collapse because of syncope, and this may be due to extreme anxiety or the frightening experience they would have had. They can have a syncope. So this is also something one needs to keep an eye on. And the tourniquet, if it is applied, please keep an eye on all the distal pulses, because there can be ischemia of the limb that can be set in if a tourniquet is applied. So when tourniquet is applied, please watch out for any limb ischemic features that one has to bear in mind and check for the pulses. So these are some of the broad clinical features. And some of the questions that one need to ask when you're dealing with a snake bite is where is the bite and whether there has been multiple bites, because not necessarily the bite can be only at one place. And what is the type of the snake? If the person who is bitten can at least recognize and explain the type of the snake, and the time lag, when was the bite noticed, because that is also very important for having to understand the severity and the treatment sort of a plan to know what has been the time lag between the presentation and the bite, and how was the how was the bite site, or how was he or she bitten by the snake, in under what circumstances, and the number of bites. I think these are some of the questions that one need to bear in mind. There are certain factors which determine the potency of snake bite. Age is a very important, and body size. So body size is important because if a venomous snake has bitten a small, maybe a child or someone with a small body size, then obviously the intensity of envenomation features will be much more severe in a small sized body as compared to the obese, because of the body surface area which determines the spread of the venom. And the number of fang marks also is important, as I said, because it is very important. If there are multiple bites, one needs to know to determine the severity of the snake bite as well, and the location of the bite. Because the more distal it is, I think the spread of the venom, the systemic features possibly maybe little less as compared to more proximal bites. So this is also something one needs to keep in mind. And the type of snake, if someone can say that it is a cobra, or if it is a viper, in their own local lingo, one may say it was Nagaravu, or if it is a Kattehavu, something of that sort. So viper would look like this. So if they can sort of indicate to you in a local language, or if they have taken a picture of the snakes, that will be very valuable in determining what type of snake has bitten them. So let us look into the clinical features of snake bite. So this is just a tabular format to indicate different types of snake bites commonly seen in India. So local pain, as you say, is present in all venomous like cobra and all these vipers. You have a pain, but kraits, as I said, they won't have even fang marks and they may not have even pain. And this may go unnoticed. That is something which can be very deceptive. And ptosis is in neurotoxic snake, which is the Elapidae or the cobra bites. And even kraits can have some neurological signs. So it can be present in both cobra and kraits, but vipers do not have neurological manifestation. Hematotoxic is predominantly seen in viper, but it can be seen in krait also. And renal complication is predominantly seen in Russell's viper and humped nose viper, but not as common in saw-scaled viper is what is mentioned. And response to neostigmine is found in neurotoxic snakes, mainly in cobra, but not in the krait. You would see a response to neostigmine. So this is just a brief, and this is quite intuitive for most intensive care trainees. Viper, hematotoxic; cobra, neurotoxic; krait, neurotoxic with some hematological features is something. And pain is caused by all except the krait. If you remember that, that should be good enough. And response to ASV is seen in all snakes except this humped nose viper. Somehow the response to anti-snake venom serum is not seen. This is something that one needs to keep in mind if it is a humped nose viper. So investigations, the key investigations that for every ICU training need to bear in mind is the only investigation which is of huge value is 20 minutes whole blood clotting time. And this is meant to be done every 30 minutes for 3 hours. So basically you draw the blood, keep it on the side, and after 20 minutes you tilt it and see if the clot is formed or if the blood is still in a liquid phase. And by now you would have possibly initiated ASV, and to see the response of ASV also, we need to keep repeating this to see whether the blood is clotting. Every 30 minutes for 3 hours is what is recommended. And after 3 hours, it needs to be done every hourly. And if it is coagulable, and it needs to be repeated every 6 hourly, and ASV will be continued and will be monitored until the blood starts clotting. So until the blood clots, you need to keep repeating this whole blood clotting time. This is very important, especially if you're answering a question for a DNB in the paper. I think this I would expect them to write very clearly that you need to keep repeating whole blood clotting time until the clotting happens, and it has to be repeated up to 3 hours every 30 minutes, every hourly and 6 hourly. and ASV has to be continued until the blood starts coagulating. So this is something very important. Other investigations, you would do complete blood count to look at it, and if there is sign of any infection, you would send cultures. You would, these are routine ICU investigations, which is expected for any of the snake bites. You have to do ABG, KFT, LFTs, urine analysis, coax, and ultrasound if there is, to look for if there is any sort of abdominal bleeds that may have happened, or if there is any serositis, and X-rays to look for any pleural effusion, so on and so forth. So these are all routine, run-of-the-mill, intuitive, archaic ICU investigations that any intensivist would consider doing. You can do CPK also to look at any muscle breakdown in these patients, but these are all standard investigations any intensivist would do. And we look into the snake bite management in general. So this is very important for intensivists because most of the ER people would know about the salient aspects of management. The general management is if a if the limb is immobilized, or if there is a crepe bandage put in, or some tourniquet put in at the site by anyone, it is important that this crepe bandage or any of the immobilization that is put has to be removed very slowly, because there will be some pressure which would have limited the spread of the venom. Because if it is suddenly removed, then there can be rapid spread of the venom. And it is important when a tourniquet for any reason has been tied to look for any distal pulses. And if distal pulses are absent, to involve the surgeons or the relevant specialists to intervene before you go on further, because the distal pulses to be seen is very important, especially when a limb mobilization, crepe bandage, or tourniquet has been put in. And this has to be removed very slowly. And as you remove, one has to be prepared. It has to be done in a monitored setting, because patients can have hemodynamic collapse or respiratory distress because of rapid spread of venom from the distal to the proximal area. And one needs to be very cautious when they are removing any sort of a tourniquet or any of the limb immobilization that may have been put. And at the site of snake bite, they can have severe pain. So analgesics of some nature has to be administered, preferably paracetamol and opioids, and NSAIDs to be avoided, because AKI, these patients would be at a risk of AKI. So now we'll talk about the main bit of management will revolve around anti-snake venom serum. So there are certain T-nets that one needs to be aware when you're administering anti-snake venom. Full dose should be administered without delay. And in India, you have polyvalent sera, which covers for all the 4 snakes. So this polyvalent sera available in India covers for the cobra bite, covers for the Russell snake, covers for the saw-scale snake, and covers for the crate. So these are the 4 snakes for which the Indian polyvalent sera that is available covers. And ASV is not effective. This is something for all our trainees to know. Anti-snake venom is not effective against hump-nosed pit viper, and it is not effective against Sochurek saw-scaled viper, which apparently is found in Rajasthan area. So Sochurek saw-scaled viper, our Indian ASV is not effective. And there is something called Kalach snake, which is a type of a crate which is present in West Bengal, against which ASV is not found to be effective or less effective. But definitely it is found to be not effective against hump-nosed pit viper. This is something which trainees can remember. And when it comes to snake venom serum, there is no absolute contraindications for administering snake venom serum. And with regards to snake venom serum, certain don'ts that needs to be kept in mind. Routine administration should not be done for all snake bites, because as I said, 70% of the snake bites are non-venomous. So it should not be administered as a routine for all snake dose. And full dose has to be administered. That is something all trainees should bear in mind. Incomplete dose is something that one should avoid. And there should not be delay in the administrating of the dose, or withholding the dose because someone has had some local reaction or systemic reaction is not a contraindication. One has to treat the reaction and continue with the ASV. So there are 2 types of ASV in India. What is available is what you see in the picture. It is freeze dried. It comes as a powder which needs to be reconstituted with the liquid which is provided along with that package. It is stable, heat stable. In India, it is heat stable. Shelf life is up to 3 to 5 years. It means it has to be kept at a cooler place, but it need not be refrigerated. Then there is a liquid form also that is available, which is heat labile. So a cold chain has to be maintained for the liquid form at 2 to 8 degrees centigrade. Cold chain has to be maintained for liquid, but not for the one that is available in India. Shelf life is only for 2 years, but the cost of this liquid one is more expensive. But what is available which we use is the dried product, freeze dried, and the shelf life is longer. It can be kept in a cool place. So this is about the snake venom. And what is the dosage for vasculotoxic snake bite, like viper? So there are two dose regimes. One is low dose infusion and one is high dose intermittent bolus. So for all trainees, pay little attention. You need to remember this so that because the whole WHO guideline emphasizes on full dose of ASV and not to give suboptimal dosage. If it is a viper, if it is a results viper, it is 10 vials. So we may not know whether it's a result viper or whether it is pit viper. So the easiest way to remember is to have 10 vials as a stat dose. If it is saw-scaled viper, they say 6 vials stat infusion over 30 minutes, followed by 2 vials 6 hourly as infusion to be given. And this has to continue until whole blood clotting time normalizes. So if you don't remember this, if you don't know which viper, better to give 10 vials followed by 2 vials 6 hourly as a dose, because if it is a high dose intermittent bolus, then you need to give total of 34 vials in 24 to 36 hours, where you give 10 vials stat, and all this stat is as infusion over 30 minutes, followed by 6 vials 6 hourly as infusion. This is high dose. So easiest for trainees to remember is 10 vials stat. If it is a low dose, it is 2 vials every 6 hourly. If it is a high dose, it is 6 vials 6 hourly as infusion. And this has to be continued until whole blood clotting time is normal. So all the trainees, the sort of ballpark that we need to keep in mind is the venom that is injected. Maximum venom is up to 147 grams. And for 1 vial, will neutralize 6 grams of venom. If you quantitate that, 25 vials will be good enough for any venom. That's why we keep at 30 vials. So here for viper, since it is more sort of a lethal with regards to hematological manifestations, you see it comes around 30 vials. So 10 vials stat, 2 vials 6 hourly, or 6 vials 6 hourly if it is a high dose you are thinking of. So how much venom and how much ASV? As I said, I said grams, it's milligram. 5 to 147 milligram is the range of venom any snake would inject, which for this to be neutralized, you need up to 30 vials, 10 to 30 vials. And if you look at exact dosage, 1 vial is needed to neutralize 6 milligram of venom. So if you calculate for 147 milligram, about 25 vials. So 30 vials will neutralize any quantity that any snake can inject into human body. So that is something. So 30 vials you can keep in mind. 10 vials as a bolus for all snakes, you can keep it. For viper, 10 vials stat, 2 vials 6 hourly, or 6 vials 6 hourly as a high dose. Even in cobra bite, it is 10 vials stat followed by another 10 vials. So if there is a capillary leak that happens, and then higher dose of anti-snake venom is sort of recommended, and higher dose of anti-snake venom with FFP is shown to reduce mortality by one of the Indian study that has been published in 2014, especially when they have a lot of surge response or a capillary leak that manifests. And with regards to anti-snake venom, one needs to bear in mind certain things. So it needs to be given slowly for first 30 minutes, and observation has to be made whether they develop any anaphylactic reaction. If patient develops any anaphylactic reaction, then that anaphylactic reaction has to be treated. You can stop briefly, treat the anaphylactic, and then you have to restart the ASV. So there is no business for us to stop ASV just because someone has had a reaction. So the whole emphasis is on treat the reaction and continue ASV. It can be stopped for a short time, but ASV has to be continued. And after the reaction settles, the infusion rate has to be increased over course of time. And one may have questions, what about in pregnancy? In pregnancy also, treatment is the same, and ASV dose is the same in pregnant, and obstetrician referral can be taken to look at the fetal situation and the status of the fetus. Otherwise, treatment is same even for pregnancy. There's no difference. How about the role of ASV in victims needing life-saving surgery? Suppose a limb is become ischemic or gangrenous and they need to go for a surgery. So what is the recommendation? So recommendation is coax has to be normalized, and if someone is needing life-threatening sort of a life-threatening situation where life-saving surgery needs to be reconstituted, you can give up to 30 vials. As I said, 30 vials are needed to neutralize vaccine. You can give 30 vials in a very short period of time before the surgery to normalize. And again, here, whole blood clotting time has to be repeated every 6 hourly and to be normalized. Here they say these ASV can be given every 2 hourly. Like I said, 10 vials stacked, then you can give 10 vials every hourly to reach up to 30 vials if patient is posted for surgery as a life-saving measure. Otherwise, you can give it as an infusion 6 vials 6 hourly or 2 vials 6 hourly. So that is what is recommendation from all the guidelines. And what about persistent coagulopathy? In spite of large doses of ASV, you have given 30 vials of ASV, still patient is having coagulopathy, then the recommendation is you can give FFP with cryoprecipitate with additional ASV if needs be to be continued if there is persistent coagulopathy. So now we'll talk about what is the dose of anti-snake venom in neurotoxic envenomation. Neurotoxic also is the same, 10 vials stat over 30 minutes. So please remember 10 vials is the standard. But in neurotoxic, if there is no improvement in 1 hour, or if they improve and then they again become weak after, if they develop ptosis or neuromuscular weakness after 2 to 3 hours or 4 to 5 hours, repeat 10 vials has to be given. So it is not 6 vials 6 hourly, 2 vials 6 hourly. All this is for Viper. In neurotoxic, 10 vials stat, and if there no improvement, give another 10 vials. So this is what is the recommendation for the neurotoxic. Maximum dose for neurotoxic is 20 vials. But as you see in Viperida, you can go up to 30 vials or even more if a persistent coagulopathy is present. So what about this question you may have, someone who has come after a late arrival. So ASV dose protocol for later, again you do 20-minute whole blood clotting time. If coagulopathy, give ASV. So that is the recommendation. Even if they come late, if coagulopathy is there, you should give ASV. So these are some of the different scenarios where you may have a bit of an ambiguity as to where we should give, where we should not. So these are all the guidelines that are well established. One could keep an eye on this. So now very quickly, last couple of slides on ASV reaction. 20 to 60% of the patients can develop reaction to ASV. There are three types of reactions. Early reactions, which happens in less than 10 to 180 minutes, which is 10 to 3 hours. And then they can have febrile reactions, which occurs in 1 to 2 hours. Then they can have a late reaction, which is like a serum sickness. It can happen up to 12 days, 1 to 12 days. So certain don'ts in ASV is no ASV test dose is needed. You don't need to give a test dose, and no skin test also is needed prior to administration of ASV. This is also something we all should bear in mind. Early anaphylactic, which happens within 3 hours, it can be any skin lesion, itching. They can have diarrhea, they can have vomiting, diaphoresis, and in severe cases, they can have bronchospasm and angioedema. Treatment is for any anaphylaxis, what would you give? You would give fluids, you would give epinephrine 1 in 1,000, and you would give Avil, which is chlorpheniramine maleate with hydrocortisone. So this is a standard, every intensivist would know. So early reaction, you would give hydrocortisone, you would give chlorpheniramine maleate, you would give steroids and fluid resistant, because in anaphylaxis, there'll be a lot of fluid shifts from the vascular compartment. So late reaction, serum sickness. So if it's a febrile reaction, you'll give temperature and supportive measure. So the late serum sickness can develop 1 to 12 days after treatment. The mean duration in which it occurs is around 7 days. So in the serum sickness, they can have fever, nausea, vomiting, diarrhea, or they can have arthralgia in the later stage, lymphadenopathy. Much later stage, they can develop immune complex nephritis or encephalitis. So these are some of the feature of late reactions that can happen due to ASV. Treatment is again Avil or chlorpheniramine maleate 2 milligram, and if it is going on to develop arthralgia, lymphadenopathy, immune complex, nephritis, and all that, one could give prednisolone 5 mg 4 times a day for 5 days and slowly to be weaned. So this is about the management of reactions that can happen to ASV. So this is the whole overview about the snake bite, and it would appear very simple for you, but since this has been asked in 2022 DNB exam, it is good to know. It's mainly for intensivists to have a grasp on the ASV regimes for hematotoxic and neurotoxic, and the investigations, which is the gold standard, is whole blood clotting time, which needs to be repeated every 30 minutes up to 3 hours and every hourly, and so on and so forth until it normalizes. And limb immobilization is to be emphasized, and all the other alternative modalities to be avoided. So this is in brief about the snake bite. So you can visit my website www.drpradeeprangappa.com to rehear to this lecture. So I end here. Thank you one and all. End with this beautiful quote. So nothing ever becomes real till it is experienced. Even a proverb is no proverb to you till your life has illustrated it. by John Keats. So thank you, Manindra.